Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
We've got a good group here joining us, everybody. I'm very excited to have Pedro Velasquez joining us from Lifedoc Health. He's the executive director there, and he's been a familiar face for us at the Learning Collaboratives. He's also a member of our Population Health Subcommittee, and he has a lot of experience in creative approaches to how to make community health workers, health coaching, and other approaches work in team-based care. So, Pedro, I will let you take it away when you're ready.
Hey, y'all. Thank you for the introduction, Ashley. We are, like Ashley said, we're an outpatient center focused on preventive care. And so everything that we've been doing the last 20 years has been focused on learning what do Memphians need and what can we do about it. And, even though we are a nonprofit today, for the first 18 years of our lives, we were a family-owned clinic. And so we've always had to make sure that everything we do is self-sustainable and that it's, a long-term program that doesn't depend on grants and donations. And so as over the last 6 years, we've been more and more involved in social risk factors and SDoH. And, what do we have to do as an organization so that we can help people navigate their healthcare and social needs in a way where it's tied to improved clinical outcomes. And so a little bit of background on the organization is that, we do primary care, endocrinology, cardiology, optometry, behavioral health, pharmacy, diagnostic imaging. And every one of those services was because the data, as a healthcare and research organization, we made those decisions because the data showed that that's what our patients need. And so in 2019, we started looking at population health and social risk factors a little bit more closely, because what we had learned is that, regardless of how well we do during the visit while we have the patient here, when they come back and whether they're stable or uncontrolled with their chronic conditions has more to do with what happens in between the appointments than, what happens during that 15, 30, or 60-minute visit. So our team-based approach had always been more focused on the medical providers that have to be a part of the team. And over the last few years, we've tried to incorporate the role of community health workers. And so community health workers is a relatively new concept to Tennessee, but it's been around for many, many years in a lot of other spots. But the whole gist of it is that, there is a person who can be accountable and responsible for helping the patients navigate and bridge the gaps between visits and between what goes on during the visit and what goes on after and in their lives. So what I'm going to share with y'all today is going to be a little bit more on how there have been certain advances in how the work being done around SDoH and social and community health workers has been taking steps into the right direction. And what I hope is that I get through these slides in like 10 or 15 minutes so that so it can become more of a conversation and we can take the conversation in any direction that y'all want. So feel free to unmute and talk about what the information on each slide. It's only 4 slides, but because definitely would be more geared at having a conversation and discussion around everything. So with that being said, let's get started. So I'm going to cover this into four, like I said, 4 slides. The first is going to be how social risk factors and SDoH and the role they play in the E&M coding and medical decision making. The second is going to be how do we know what codes to select in terms of diagnosing people with social risk factors? The third is that in January 1st of 2024, so, just over 3 months ago, CMS did publish for the first time specific coding for SDoH risk assessments and community health integration, or, services, which to us is the same as, CHW services. And then lastly, around even for patients that don't really qualify for individual coding, what we've done in this organization is train different people, whether that's nurses, health coaches, care coordinators, or other clinical staff on SDoH so that they can incorporate it into the services that they're already rendering and make it a better, more effective conversation. And, that last one is far from where we would like to be and where we need to be, but it's still helpful in terms of compliance. So I'll touch on all 4 of those things. The first one is the American Medical Association in 2021 made a significant change in how E&M codes are selected. And I'm gonna, E&M codes, for an outpatient setting range from 99211 to 99215 or 99201 to 99205 for new patients. And so the complexity of the visit, one of the biggest differences between before 2021 and after 2021 is that the main determining factor and really what determines which level of code to use is medical decision making. Many of y'all may remember from the last, 30 years that it had to do a lot more with, either counting time or, counting boxes of how many ROSs did you select and how many HPI elements or examination and systems and all that stuff that, made it a little bit more tedious and sometimes even less focused on what the patient was even there to discuss. So in 2021, the AMA published a updated guidelines that said that, history and examinations should be as needed for the complexity and reason for the visit, but it's not a determination for the level selected. So I put a link down here to this document, and the document, I'm gonna see if y'all can follow along and see what I pull up. But the document is this. It was, again, published by the AMA. And the reason that I'm talking to y'all about E&M coding is because even though this is a 42-page document for the first, and let me know if y'all don't see the document that I have pulled up, but for the first 15 pages, and I know that sounds, intimidating to review 16 pages of coding, but I think it's really useful because it gets to a chart where it determines, the criteria for medical decision making. And so for medical decision making, it's the number of problems, the acuity of the problem, and the risk of complications or mortality of patient management. Okay. And what I want to scroll down is that one of the newer things that didn't used to be included in this is this language down here. One of the things that increases the complexity of the visit is the diagnosis or treatment. Is it significantly impacted by social determinants of health? And so if there are presence of social determinants of health, then that helps make it a moderate complexity, or increase the complexity of the visit depending on what's going on and how is that going to impact the patient's ability to take care of them. And that may be directly or indirectly, whether that's, they don't have insurance and can't afford medications, or that they don't have transportation and can't get to the pharmacy, but all that increases complexity of that person actually getting care. So adding that into the documentation, into how we are acknowledging the fact that these patients are more complex, and then what we do about it helps determine the complexity of the visit, whereas that didn't really used to be very clear before. So I would encourage everybody to review those updated guidelines that have updates on whether you do medical decision-making coding or time-based coding. But either way, the certain amount of effort put into medical decision-making or into SDoH, identifying social risk factors and addressing them, could influence the complexity of the visit. Again, I'm not offering this as the ideal solution, because eventually the goal is not just to identify issues, but to resolve them. And so we do need to continue down the path of, how can we make the work of identifying and following up on SDoH separately reimbursable to the office visit. However, it is a significant thing to take into account, whether you can document this and the providers start putting this to show why their patients are more difficult to manage than, the typical ones. For us, that's, 90% of our patients are Medicaid or uninsured. And so when we can incorporate that, it helps. The coding for that they would select are the diagnosis codes, which y'all may or may not be aware of, because there's not a whole bunch of noise made around diagnosing social risk factors. And so, unlike medical conditions, support and ancillary staff can add these diagnosis codes. A community health worker that is screening the patient, or a health coach or a nurse that's identifying these issues can add social risk factors Z codes. And so the link that I included is a little bit of overview of what are the Z codes. This is a CMS document that links you to how to select the appropriate Z code and examples of the most common ones. But it also has some resources that y'all can use depending on your level of interest and, on what other codes exist and how can we streamline it for the staff to incorporate them. Because, for example, what we did is we use eClinicalWorks, and we created a smart form. So as the CHW, completes it, it automatically pulls in the code. So we're not asking the provider to necessarily either be the person to identify the need or even code for it themselves by trying to train them on, all the different Z codes. You can set up the system and workflows for the whole team to be a part of incorporating this into your practice. So this is a helpful link that can that y'all could reference when trying to start selecting or improve something to workflow on how y'all can make it a little bit smoother for the team. And then I referenced where on January 1st, CMS released some coding guidelines that allow providers to code for SDoH risk assessment, as well as what they call community health integration services, which is what, falls under the work being done by community health workers. And so this is really a big step in the right direction, because, for the first time, there's a rate tied to services rendered by staff and healthcare professionals like community health workers. And even though this is only a few months new, there are some FAQs. And so again, the link that I'm going to include in this that y'all are going to receive is the document created by CMS for social determinants of health risk assessment, where it's a 15-page document, but if you scroll down to where it says social determinant of health risk assessment, it talks to you about the new code G0136 and how to use it, who can use it, when it can be used. And then it also, if you keep scrolling down a little bit, it talks about the community health integration services, which are mainly two codes, G0019 and G0022, which beginning January 1st can be used to follow up on identified SDoH needs. And their wording is it's either by the provider or ancillary staff with under the scope of service that's practicing under their scope of service, and that includes community health workers. So these guidelines, I guess, are vague to a certain degree because it's a new service. You know, CMS tends to specify more as time goes on and adds criteria as we learn more. But right now, it's meant to be used by organizations that are treating patients or following up with patients for SDoH needs. And so I can answer some questions around this, but when we get to the conversation of part of the meeting, but I want y'all are going to have access to this entire document as well. And then lastly, I wanted to let y'all know about what we do at Lifedoc Health, which is we have a team-based approach, like I said before. So we have providers, we have nurses, we have health coaches, we have care coordinators, we have community health workers, and all of them have been working under their own models of sustainability. You know, providers bill for the office visits, health coaches bill for education, pharmacists bill for things like MTM and other counseling services, and, you know, nurses and community health workers and care coordinators are eligible for being a part of different reimbursement models. And so one of the things that we wanted to do is how can we make existing reimbursement models more effective by trying to make things around building better relationships with the patients that will lead to better outcomes through understanding what's going on in their lives and not just, you know, focused on sharing education information with them, but actually, you know, building trust, getting to know the patient, understanding what's getting in the way of them managing their medication, taking care of their diabetes, or doing that. So by having a more comprehensive conversation, these services that are standalone in their own reimbursement models are able to also support the use of social risk factors in terms of identifying them and to a certain degree guiding patients. But, you know, the reason I say that this is far from ideal is because, you know, we wouldn't be during a diabetes education session, you're focused on diabetes education. So although you can acknowledge social risk factors, you have 30 minutes to provide diabetes education. And so this doesn't necessarily qualify for separate reimbursement for just following up and getting people connected to the right places and all that additional back-end work that the CMS codes allow for. But this is something where those interactions with the care team can be more meaningful if they incorporate SDoH into the care plans and follow-up conversations that are had as each one of these counseling, education, and management services is rendered. And so, again, as promised, I didn't want this learning collaborative to be me just talking to y'all about what we do, and I wanted it to be more specific to what can be helpful for y'all. because we have been doing this work for a while. We've ran a few pilots, and so what I wanted to share is what's accessible and implementable by anybody, regardless of you participating in a specific program or pilot. And so open to questions or conversations or concerns.
This is a great presentation, Pedro. Thank you.
You're welcome.
So I've been aware of these Z codes for a while, but have not gotten anywhere in conversations with people about using them. I mean, what is this a CMS specific initiative, and is there a drawback to focusing on the Z codes with the private health insurers?
So the Z codes is how we would report up here, where I said that medical decision making is now determined, or that E&M coding is now determined, solely on medical decision making and complexity of the visit. That's where Z coding would help provide some context into the complexity of the patient, right?
Okay.
So regardless of whether it's Medicaid, Medicare, or private pay, the AMA coding guidelines, are the coding guidelines. So whatever determines complexity of visit is true regardless of the insurance that they have. So to a certain degree, Z coding is helpful if it's done in a way where we are reporting that this person is, without a job, without transportation, and and if our documentation, it can be a sentence or two that just specifies, why does this get in the way of them being able to manage them? Or why does this make this more complex? People that depend on mail order or that don't have access to the coverage, all of those things, as long as we can add the Z codes, we can start providing payers with the context to support the complexity of the visit. So this coding guideline published by the AMA was something that I was excited to see, where it had a few things that are good. So I would encourage everybody to read through the entire coding update, but specifically for SDoH, it makes it a part of the medical and complexity of the visit.
Okay.
So if somebody in the practice is a part of today's visit identifies a risk factor, then that's incorporated into the progress note, it would be reported as a Z code. And every practice is different, right? So some practices, the EMR system will pull in codes like we have as we document. The coding is done. Others have the providers select the diagnosis codes. Others have coders that read the documentation and pull in the codes. Regardless of what your workflow is, there is a way of incorporating it in a way where it's not as burdensome on the provider to have to identify and document all these things on their own.
Okay. All right. That was
Does that
excellent.
answer your question, Corey?
Yes, it does. Thank you.
You're welcome.
Could I ask you to elaborate more on this complexity of the visit? I understand that now you get reimbursed for collecting the social determinants of health, do the assessment about this. But has the complexity of the visit any other implications on the billing, or which procedures or services would be reimbursable?
Yeah, so because since 2001, the E&M codes have been, the E&M guidelines updated to say that, instead of making sure we had a certain number of elements in examination and ROS and history, because all that changed, and now it's mainly so based on the complexity of the visit and medical decision making, then the level of the code is more determined by what's actually going on with the patient and what's the provider going to do about it, or what makes this a harder or easier patient to treat and the risk associated to it. So when we are making documentation on medical decision-making, there are three main buckets, right? The number and complexity of the problem, the amount of data to be reviewed, like referrals, lab work, prescriptions, procedures, all those things, and the risk of complications, okay? And so when I scroll down here to what supports a moderate decision-making, which is a level 4 decision-making, or a level 4 visit, we can see that the AMA included the diagnosis or treatment is significantly limited by social determinants of health. So by documenting that this person is experiencing social determinants of health that get in the way of their, or that make it more complicated and complex for them to take care of their condition, it helps support the added complexity of that visit. And on the other side, if you are, instead of doing medical decision-making coding, and instead you're using time-based coding, then there's also updates to time-based coding guidelines where a lot of the work spent by the provider on the front end and back end of the visit, it's not just face-to-face with the patient anymore, but some of the work being done on the front end and back end is also part of the time. So I would encourage everybody to sort of get very familiar with that, because it's very different than what was actually in place for, 20, 30 years and how people are used to coding. It's not only based on face-to-face time. It's not only based on the boxes that we check in the progress note. It's now mainly based on what does the patient need and what is the provider and the team doing about it while they're here for that visit. Does that answer your question?
Yes, thank you.
You're welcome.
Hey, Pedro, this is Stuart Johnson chatted in a question, and I'm doing it by memory. Stuart, why don't you state your question, and then I think I might can help with some information related to your question.
Yeah, of course. Hey, Sai. Hey, everybody. My question was, is there a line of sight into when Medicaid will begin reimbursing for the three codes that Pedro mentioned earlier on? So those were G0136, G0019, and G0022. Thank you.
Yeah, so I'm not sure I can, I'm kind of familiar to speak to each end of those three codes individually, but if I just get to the general question of, the coding for SDoH risk assessment and the CHI services, community health integration services, those couple of codes I know, G0019 and G0022. So for TennCare, the goal, many of you know, TennCare has their own workforce development initiative that's been underway, and put out a series of CHW infrastructure grants. There are X number of practices and community-based organizations that applied and got in the program. And if it hasn't happened already, pretty soon they're going to put out another wave of opportunities for practices to sign up for that. Now, again, I'm not an expert, but what I want to say about that is that it's not really to pay for hiring community health workers. So there's a lot of other services that come with that grant, and I won't get into the details, but the direct answer to your question, Stuart, is their goal, and this is a goal, is that community health worker services will become a covered benefit for TennCare beneficiaries by July 1st, 2025, but depends on how things go, and CMS must approve that for Medicaid to do so. So that is the current landscape and plan for TennCare. And TennCare should, probably answer more than me, even though I talk to them all the time, obviously, from Blue Care, a Medicaid MCO. But that is the plan. And so currently it's not a covered benefit, and the Medicaid MCOs cannot pay for any billed services for CHWs with those codes until all that happens. And then, so more to come, summer of 2025 in regards to direct payment for the services rendered by community health workers. And so they, again, I'm kind of speaking for TennCare, let's just speak for themselves, but they have, done a lot of work, got a consultant that's helping with that whole process. And so that's the answer, is sometime on or after July 1st of 2025, it would be a covered benefit, and those services reimbursed by all 3 Medicaid MCOs. So that's the hardcore answer, and hope that's helpful. Now, Pedro, you've done a fabulous job today. I just have to tell you, what a great presentation, and the opportunities you've identified for, E&M coding, and how you can, bring the social risk factors, or the Z codes, into, basic coding, E&M coding. That was really well done. And you're right, everybody has to study it for themselves and determine that, you've got an approach that's compliant and will be helpful to your patients, that sort of thing. But what a great job, Pedro. Thank you.
Well, yeah, and thank you, Dr. Huffman. That was very good response, and I'm glad to know that there is a date in mind. I was gonna offer some of the same information, that I don't foresee anything really happening within the next year, but I'm hopeful, because usually when CMS does an update, sort of like when CCM rolled out first with CMS and then with Medicaid, people tend to have a clearer path forward once something happens at the CMS level. So, and I agree that, the role that SDoH can play in the complexity of the visit is a added benefit to see how we can help identify and sort of elaborate on why this patient is complex. The caveat obviously is that, the E&M code wouldn't necessarily provide the reimbursement for resolving that SDoH need, or helping the patient resolve that condition, because that's more ongoing follow-up and things like that. But for the visit, it can be beneficial, and with that data, we can continue to take steps in the right direction. So, I would say start collecting the data, reporting the things, and that way we can all be a part of helping the payers and the state, know why this is so important, and why this is what's actually going on in the community.
I completely agree, Pedro. And, Corey said something in terms of trying to get providers interested, whatever it is you said there, Corey. From a Medicaid MCO perspective, same thing here for us. And there's the TennCare Health Starts program that people are aware of. And so certain practices are participating in that. And that's kind of like a program going around capturing social risk factors, social risk factors, making referrals to community-based organizations, and then closing the loop. And so that's a whole big TennCare initiative. It's been going on for, seems like, more than 2 years now. And so it continues to evolve. But so some practices are getting some level of compensation from the MCOs through that Health Starts program. but it's not a broad program available to everybody just right now. But I don't know if that's helpful or not to know. But the thing is, what Pedro shared is just absolutely fundamental. The one thing he shared, he worked with ECW, okay, so that they build in the EHR. I think I heard you say this right, because I know it's possible. I'm talking to ECW myself several times recently, is, and I don't know about all the vendors, right? But at least ECW, they have the capability of building codes in, and there's some even more nuanced things, other kinds of codes that can be built within an EHR where honestly, all the data is captured and your staff just do their work. And you don't have to worry so much about coding the right Z code and all that. So all the major EHR vendors, I mean, the bigger ones across America, are at the table with CMS, they're at the table with NCQA, which is important to health plans, and they're all getting this worked out. But the fundamental thing of working with your EHR vendor in whatever way you can to make the work more efficient in capturing the data, and then eventually, has that data get exchanged, and something other than a claim will be something that'll come up in the future. I'll just kind of give you a teaser for the future, because CMS, when I've been on a few seminars or webinars, whatever they all are, and been a Google fool, going to see what I could learn about their intent. And I do believe the intent for HHS through CMS sort of kind of goes Medicare, and then there's some state level thing about what's decided about Medicaid, right? That's just the way it is. But it all flows down from CMS. And what I'm really getting to is there's one fundamental thing that was stated more than once, is CMS really wants to see social care integrated into clinical care. Okay, so that's clear, including all the whole things that came out effective January 2024. But the point is, this is the other key point that I've discerned in a couple of meetings, is they do want to level the playing field. They want to recognize the complexity, and you see it in the E&M coding that came out from AMA, right? So there's that opportunity, but CMS is hoping to account for the social risk of the patients you are serving, your population. That's an ultimate goal they have. Well, the only way you can get in front of that is start screening and start capturing the Z codes, right? If you want to prepare yourself for the future, start now. I'm just reinforcing what Pedro said. That's just my advice to anybody. Yeah, there's a question in there about by clinician type. If you look at, Pedro is scanning through, and Ashley Ellis is on the call. She and I are working on some things together. What providers can do this? Well, yeah, there's some guidance in the FAQs that not in this AMA document, but the other that, that you pull up, and it had like physicians, NPs, PAs, etc., right?
So can y'all see this, my screen and the CMS document, the CMS
Yes,
FAQs?
we can.
Okay. So who can perform SDoH risk assessment? This is their answer for the risk assessment. And then I'll scroll down so that y'all can see what their answer is for who can provide CHI, community health services. So it does say by a treating physician or other practitioner, or by auxiliary personnel under the general supervision of the billing practitioner. So again, everything not falling on the provider and on the provider's time with the patient is definitely crucial for any sort of healthcare advancement, where a lot of times practices seem to be under the impression that the doctor has to do everything themselves. And so this auxiliary personnel is a key part of this actually being implementable in a realistic setting. That and then when you scroll down, who can bill for CHI services? Again, question number 6. They're generally provided by auxiliary personnel, incident to and under the general supervision of the professional services of the billing physician or other practitioner. So it can be furnished and billed by physicians and PAs, all these acronyms, and must be billed under that person, but they are generally provided by, again, ancillary or auxiliary staff, and not just, taking over the provider's visit time with the patient. Did I answer that question? And Sai, do you want to elaborate anything? Was that a sufficient?
I will. And so just briefly, and like I said, Ashley Ellis and I are in the weeds on this, along with others at UTHSC staff and the Medicaid MCOs. And we have to, obviously for Medicaid, we have to, vet everything with TennCare. But that incident to term that was mentioned in one of the other paragraphs, that's something that that means it's kind of self-evident, incident to, but it means before the Medicaid MCOs can pay claims for incident to services, we have to have TennCare approval. So we did get that approval for the health coaches under supervision of pretty much the same list of licensed providers. So that's in effect now approved for health coaching. The CHW piece has not been determined, just because, like I said, TennCare's got their own timeline. And so for the Tennessee Heart Health Initiative, we're all kind of part of that. Context of this call is that, it's now set up to do so for health coaches. Got TennCare approval that the MCOs could do that. But there's also, part of the whole Heart Health Network, and many of you, hopefully all of you have seen this or been on a webinar that explains this about the training and certification standards for health coaches and under the Heart Health Network. And that was worked out. Susan Butterworth and others, everybody worked that out and agreed on it, and the MCOs agreed to it. Then the CHW standards, though, are going to be defined by TennCare, and they've got an accreditation body set up and things like that. So they're getting the infrastructure in place and all the requirements for that hope for 2025, final dispensation regarding community health workers. So, but it'll be very similar, but I think the nuances will be, there's several nuances. I don't even sort of say, I don't know how it's going to turn out. I have my own ideas, but I don't know for sure what that will look like. Sorry, that may have been too rambling of an answer there, but I hope it helped.
I think it does. And I think, what that certification looks like, what auxiliary personnel means, because it is including community health workers, but not just community health workers that can do those type of things. And so, people that are trained or certified in these competencies and things like that are things that CMS has included. And like Sai said, for Medicaid and TennCare to adopt these things will probably take some more conversations and understanding and implementing and all that fun stuff. But for y'all to review this document and start asking questions to the to CMS and providing context, obviously they can answer some other things. One of the key differences between the 3 codes as well is that the risk assessment code has to be provided in person during the time of a visit, while the CHI services can be provided remotely. And I did want to specify that as well, so that if y'all are, again, that's all included in this document, so read through it, but I did want to specify that the CHI services is on Medicare's approved list of remote services to be provided. So there's good news there as well. That means that it's more implementable. But
Pedro,
go
I
ahead.
was just going to jump in, like with the remote telehealth kind of component to it. I put in the chat what the definition of general supervision is, just for anybody who is unclear, because that can be important. But that's also the language that's used for CCM and RPM. So if you're thinking about hiring someone and the feasibility, if you needed to share a person or share it across clinics, you don't have to physically be under the same roof like you would with an incident to type of billing. So you could be working on Lifedoc this location, Lifedoc that location, etc., and still be working on that code to fill up their schedule.
Perfect. Thank you, Ashley.
One thing that to just point out is we keep talking about, and we should talk about Medicaid, and that's my space, my primary space. But I got to tell you, as I understand it, all this is available for Medicare right now.
It's available for Medicare. And, you know, I had a question too, Pedro. So you were talking about the goal is right now it's identification, right? And the goal is to make intervention and to recoup revenue payment for those services. Do you know anything about if there will be upcoming public comment or anything like that, or a way to advocate for that?
You mean like for CMS? Like,
Yes.
yeah, they have a list. It's on their website. I don't have it off the like at my fingertips, but they do have some meetings throughout the year where there's opportunities for people to be a part of the conversation. I can see if I can find what that is and send it over when I send this presentation, okay?
Yeah, and if you know if that's something that's coming up, that because it looks like a lot of people are really interested in this, if you think that would be useful or to have a lot of people put comments on, we can always put that in our newsletter or social media.
That sounds good. Thank you.
Well, I have a question.
Hey, Sai, sorry, go ahead, Ezra.
Hi, I am a medical geographer. I don't have a clinical background, but I map social determinants of health. And in the past, we extracted social determinants of health by location and areal boundaries by census. So now there is an opportunity to map these Z codes, social risk factors, Z codes, to find out the areas that have unmet social determinant of health needs. Is there an effort on this, mapping efforts?
We are we're a healthcare organization, but we're healthcare and research. So we publish everything that we do and we try to see how it's tied to outcomes and all these things. So personally, our organization does invest a lot in terms of how do you analyze this? In terms of other initiatives around how to map it at a city level, I know that there's a lot of, organizations out there. I can't name any off the top of my head that are specifically focused on mapping Z coding or anything like that. But maybe Dr. Huffman, are you aware of how the MCOs are using this data to sort of map out the population?
Well, I would say that's an ultimate objective of the state of Tennessee, TennCare being one of the entities. The Department of Health has a interest in such things as well. So it's my understanding, and they'd have to speak for themselves, but it's my understanding from conversations that really is a big purpose, is to understand what's going on in communities and not just use like USDA for food deficits or something like that. Nothing wrong with that, but to get at patient reported or patient and family reported needs, right? That's where, and as far as, so just to give you an idea where our interest is for Blue Care and all of Blue Cross Blue Shield of Tennessee is that, this is not a commercial for Blue Cross Blue Shield of Tennessee, but the board of Blue Cross Blue Shield of Tennessee made a major commitment to health equity. They just said it. And then you go on the website and you see the current report, and there's lots of stuff going on to try to better understand what's going on with the Blue Cross of Tennessee membership, right? And Blue Care is a piece of that. And so we also, NCQA is big for health plans, right? That's the accrediting body. And so what I'm getting at is Blue Care is the first, one of the very first Medicaid MCOs, certainly the first one in Tennessee, the only one right now. Again, it's not a commercial, to get NCQA health equity accreditation. And they have standards. And part of those standards are, how are you going from this imputed data from Experian or just using the USDA or something like that to get at your question, to getting it straight from the individuals and their families? Okay, and that's a standard for health plans that want to pursue that level of NCQA accreditation. So we're working on it all the time. So we're trying to encourage providers, and unfortunately, it's just kind of encouraging at this point. Back to Corey's point earlier, it's like, hey, we'd like for you all to collect some of this data. It's like, well, what am I get paid for it? Well, for some of them, nothing. Right now, because they're not in the Health Starts program, a 10-care thing that we get money to kind of work with practices. It's like, it's for the future, right? And I think so anyway, back to the issue, I do believe it's a priority for the state of Tennessee to get a better understanding of what's really going on community by community, and so I hope that helps. But it's really important not just to use imputed data, right, to determine what's going on in the community. You need to talk to the people, and that needs to be recorded. It needs to be aggregated, and we already aggregate it, in our own way for Blue Care. And so I know we built a dashboard, and, for example, if I want to go in today, I can say, well, just the way we measure our social risk index these days, and we've been working on this for the whole time I've been at Blue Cross, which is 11 years. We've continued to iterate that. It's like a CDC model for social vulnerability index, but we've iterated beyond that, and we're trying to say, but anyway, I can look at a dashboard, look up Lifedoc Health and a community care dashboard and say, well, from our viewpoint with the data we have so far and all our data sources, this is a social risk index for the population of our members assigned to Lifedoc Health. I can do that for any primary care practice in Tennessee now, but we've been working on that a long time. So it's not like it's driven lots of decisions yet, but we're trying to prepare for the future too. And we're trying to get this social care integration into clinical care, and we can only go as fast as the entire system will allow us. But I hope that some of that kind of hits on what you're asking, in terms of, I'm glad you're an ethnographer. I think you said you were. I think that's the coolest thing. I heard about people like you a long time ago. I think that's really cool what you do.
Well, thank you. Is it possible that you can put the link to your dashboard?
If I were more skilled, I would right now, but I tell you what I'll do. We'll send that out, and work with Ashley also knows. We can post that, and I need to get the exact link so you don't have to navigate the entire website. You know what I'm saying? But the view I was talking about is not publicly viewable. We do have discussions with practices that we work with routinely about the social risk index, but the website that has all the health equity data, absolutely. I'll just find the best link for you to hit without navigating the entire website. How about that?
Okay, thank you.
And Sai, you touched on this, and for everybody's benefit, as the state is developing their certification requirements, there's now I guess, governing board of community health workers that are going to be validating programs and certifying community health workers. One question I did have for you, Sai, I guess, and sorry to put you on the spot, but from what I understood in the most recent webinar, the Impact program and the Vanderbilt program have been approved, I guess, as a certifying program. Are you aware of whether the UT program is also going to be included in the approved list of certifying community health workers or training community health workers?
I am not for sure. It's a great question. I think that, that's 10Care, leading that. I do know that, as you know, the State Community Health Workers Association is the accrediting organization that was chosen, but who are the certified trainers, training sites and certification sites? I just don't know the answer to that, Pedro. It's a great question.
Well, then I'll just leave that question floating around in your brain for whenever you and Jim and Susan are talking to see if there's a path.
And next time I talk to 10Care, I can ask, and that's probably going to be like today or tomorrow. I mean, like it's, I mean, no kidding. I mean, the Health Stars program has grown a lot, and so not anybody cares, but it probably occupies 20% of my work time now. So,
well, if you do hear anything back, could you let me know if I can help.
I will. I'll let you know.
All right, thank you. I know we're running close on time, so any other questions that that anybody has around what we covered today?
I want to say thank you to Pedro, and thank you to our audience today, who's been so interactive and asking great questions. And I know there's a lot of work to be done in this area, serve our patients as best we can, and to continue to move this forward. It looks like there's a lot of interaction and engagement on this topic, so we will continue to follow this and bring you as much information as we can. So this webinar will be posted, and I will also get the link from Sai. I will send that out by email, and I will post it with this recording as well. So thanks for joining us. Y'all have a great day.
Y'all as well. Thank you.
Thank you.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.